Welcome to The Explainer. Today, we're diving straight into unraveling a massive mathematical mystery hidden deep inside medical screening data. We constantly hear that catching a disease early is the absolute ultimate key to surviving it. But what if the data we rely on to prove that is actually playing a trick on our minds? What if some of our greatest medical victories are, in reality, just statistical illusions?
So, does early detection always mean a longer life? I mean, it kind of feels like a trick question, doesn't it? Our fundamental assumption, hammered into us by years of public health campaigns, is that early detection absolutely extends life. But as we pull back the curtain on the actual biostatistics used to evaluate medical tests, we're going to see that this isn't always the case.
Here's our roadmap for solving the statistical mystery. First, the early detection illusion, then understanding lead time bias, followed by the length time bias trap, the overdiagnosis dilemma, and finally, proving true clinical value.
All right, part 1, the early detection illusion.
The universal assumption is this: if a screening test catches a deadly disease earlier, the patient lives longer. It seems like absolute common sense, right? You find a tumor earlier, you treat it earlier, and the patient survives longer. But in the realm of biostatistics, this exact assumption can actually serve as the basis for a massive deception in survival data. It all really boils down to how you measure survival time, and crucially, when you start the clock.
Which brings us to part 2, understanding lead time bias.
Okay, imagine a progressive, fatal oncological disease. Let's call this our patient zero scenario. Without any screening whatsoever, a subclinical tumor is present at age 55, but the patient feels totally fine. Clinical symptoms finally manifest at age 60, and sadly, death inevitably occurs at age 65. That establishes a true survival time of exactly 5 years after symptom onset.
Now, what happens when we introduce a highly sensitive screening test? Let's say it identifies that exact same subclinical tumor 5 years earlier, right at age 55. The patient is diagnosed at 55, but the natural history of the disease doesn't change one bit. Symptoms still manifest at 60, and death still occurs at age 65. On paper, we now have a full 10 years between the date of diagnosis and death. So I've got to ask you, did this patient actually live a single day longer? No way. They passed away at age 65 in both scenarios. That apparent 10-year survival time is a complete mathematical mirage. It looks like their survival time doubled, but in reality, all the test did was give them 5 extra years of knowing about the disease. This phenomenon is known as lead time bias. It's an apparent survival increase purely due to earlier disease detection without any actual change in the disease course or delay in the moment of death. The test just advanced the diagnosis date, it didn't delay the Grim Reaper. If you're tackling medical board exams, you absolutely must suspect lead time bias whenever a study claims a test increases survival time but fails to show a decrease in overall disease-specific mortality.
Moving right along to part 3, the length time bias trap.
A totally separate systematic distortion occurs because of how tumors naturally grow. Within any population, a single disease can exhibit wildly variable biological behavior. You've got rapidly growing, highly aggressive tumors that have a very short asymptomatic phase. They quickly cause severe symptoms that force patients to seek urgent medical attention completely outside of routine screening intervals. Conversely, you have slowly growing indolent tumors. These spend a massive amount of time flying under the radar, making them highly available to be caught by a routine screening test.
This dynamic creates length time bias because periodic screening preferentially captures the slow runners, those cases with long latency periods. The screen group naturally demonstrates a much better prognosis. This creates a completely false impression that the screening program is highly effective at saving lives, when in reality, the screen group was simply pre-selected to contain patients with inherently slower-moving, less aggressive forms of the disease.
All right, part 4, the overdiagnosis dilemma.
There is a really dangerous domino effect at play here. First, a highly sensitive screening program identifies a tiny, indolent abnormality, like a completely harmless thyroid or prostate lesion. Suddenly, a totally healthy individual is slapped with the label of a patient. This triggers severe anxiety and exposes them to the cascading risks of aggressive medical interventions, like unnecessary toxic therapies or surgeries.
This is overdiagnosis bias, which is essentially the extreme manifestation of length time bias. It happens when screening uncovers subclinical abnormalities that would never have progressed to cause symptoms or death during the patient's natural lifetime.
Early detection here offered zero survival benefit, but heavily burdened the patient with immense psychological and physical harm. It literally transforms healthy people into unnecessary patients.
Finally, we reach part 5, proving true clinical value.
To definitively neutralize all these statistical illusions, investigators simply cannot rely on survival rates or time-to-death metrics starting from the date of diagnosis. That metric is deeply flawed and easily manipulated. Instead, the ultimate standard of truth, the one heavily relied upon for medical board examinations and rigorous clinical guidelines, is a long-term randomized controlled trial, or RCT.
Inside those randomized controlled trials, what exact metric proves true clinical value? They are looking for a statistically significant reduction in the absolute population-wide disease-specific mortality rate over a long timeline. It is the only mathematical way to prove a screening program works. If the absolute mortality rate across the population doesn't drop, the test isn't actually saving lives. It's just playing tricks with the clock.
We've covered a lot of ground today, peeling back the layers of how medical data can sometimes create a really convincing illusion of prolonged survival. Lead time, length time, and overdiagnosis biases are incredibly powerful traps. So I'll leave you with this. The next time a headline claims a flashy new medical test literally doubles your survival time, what are you going to ask? Will you accept the illusion, or will you ask to see the absolute mortality rate? Keep questioning the data, keep learning, and thank you so much for joining me for this explainer.